I'm supposed to answer to this question, will we see the back of drug-drug interaction? And I can say definitively yes. David Begg had a major impact on antiretroviral drug-drug interaction, and you will understand why. So cyclosporin, one of the first HIV protease inhibitors in use, is characterized by a high first-pass effect, which results in a low bioavailability. So David Begg had the idea to co-administer cyclosporin for the first time in patients with the strong CYP3A4 inhibitor ritonavir in order to increase cyclosporin exposure. And you can see that it worked pretty well because with a dose of ritonavir 300 milligram twice daily, this led to a massive increase in cyclosporin exposure. AUC was increased by 58-fold. The use of ritonavir as a pharmacokinetic booster has not only been limited to cyclosporin, but has been used later on to other HIV protease inhibitors, and more recently with the new HCV protease inhibitors, Raltegravir. And you can see that addition of ritonavir will increase the Cmax, AUC, half-life, which allows to give the drug once daily and use a dose that is much lower than what you would need otherwise without the pharmacokinetic booster. So somehow with the ritonavir boosting concept, David Begg has acted as a perpetrator of drug-drug interaction, isn't it? Indeed, the inhibitory effect of CYP3A4 by ritonavir will not only increase the amount of cyclosporin or Raltegravir escaping intestinal and hepatic metabolism, but also the amount of any other drugs that is substrate of CYP3A4, thereby causing unwanted drug-drug interaction. So if the effect of the boosting effect on cyclosporin has been attributed initially only to the inhibitory effect of CYP3A4, it has been clear later on that inhibition of efflux transporters such as PGP also contribute to the increased absorption of cyclosporin. Over the years, many more drug transporters have been discovered, and we have also acquired more knowledge about their function, their transport function, and their localization, thereby understanding better what is their role in drug disposition and their contribution in drug-drug interaction. And you can see, for instance, that if you inhibit efflux transporters such as PGP or BCRP that are located at the intestinal level, this will actually increase the amount of drug that is absorbed. Or, for instance, if you inhibit the hepatic uptake transporter OATP1B1, this will actually limit the amount of drug that enters in the hepatocyte where it will be subsequently metabolized. So it is important to characterize what are the interaction of HIV and HCV drugs with this drug transporter. As illustrated here, they can impact the intestinal absorption, the hepatic uptake, biliary or renal excretion. And actually, David Begg and Andrew Owen, his team, they have really contributed to better, to provide information about the interaction of antiretroviral drug with drug transporters. This table summarizes what are the current knowledge in terms of interaction of HIV drug with drug transporters. And you can see, for instance, that tenofovir disoproxil and tenofovir alafenamide are substrate of PGP. You can see that tenofovir, labeled here as TFV, is a substrate of the renal transporter OAT1 and MRP4. For HCV drugs, you can see that a lot of these drugs are substrate of PGP and BCRP, and some of these drugs do also inhibit this transporter. And therefore, they can impact the co-administration of drug substrate, such as tenofovir alafenamide or tenofovir disoproxil. And you can see indeed here that tenofovir systemic concentration increases in patients that are that receive ledipasvir sofosbuvir as a result of the inhibition of these intestinal transporters. Similarly, boosted protease inhibitors will also increase tenofovir systemic concentration, and in patients that receive both ledipasvir sofosbuvir with boosted protease inhibitor, you observe even a higher increase in tenofovir systemic concentration. But it is important to remind that this type of interaction occurs with the prodrug of tenofovir, as illustrated here. As you know, the efflux transporter use the hydrolysis of ATP as an energy source to efflux the drug out of the membrane. So if you measure the hydrolysis of ATP, this gives you a direct measure of the efflux activity of your transporter. And you have represented here the PGP ATPase activity profile of tenofovir disoproxil and tenofovir. And you can see that you can detect some hydrolysis of ATP in presence of tenofovir disoproxil, which means that tenofovir disoproxil is a substrate of PGP. But when you look at tenofovir, you see that there is no hydrolysis of ATP, so it's not a substrate of PGP. And this explains why when you give boosted protease inhibitors or sofosbuvir, ledipasvir, you will actually inhibit intestinal PGP, and this will result in more prodrug being absorbed, which will be converted to tenofovir, and this is why you observe this higher systemic concentration. The same goes for tenofovir alafenamide. It's also a substrate of PGP, and when you give it with a PGP inhibitor such as cobicistar, this will result in more TAF being absorbed. And actually, you should give TAF at a dosage of 25 milligram in absence of PGP inhibitors and at 10 milligram in presence of PGP inhibitors. So if we have seen that the prodrug of tenofovir can be victim of drug-drug interaction at the intestinal level, tenofovir, on the other hand, can be victim of drug-drug interaction at the renal level, and this is because it's transported by the renal transporter into the tubular cell and excreted via MRP4 in the urine. And as you know, if you give inhibitor of MRP4, you will limit the excretion of tenofovir, which will result in more tenofovir staying inside the tubular cell and thus an increased risk of tubular toxicity. So altogether, this example shows you that it is important to consider a drug transporter when evaluating the potential for drug-drug interaction. Besides drug transporters, as you know, drug-drug interaction with HIV therapy occur via inhibition or induction of cytochrome. This is a topic that you know very well. If we look at HCV drugs, you can see that some of these drugs are also metabolized by the CYP3A4, and some of them, like boceprevir, telaprevir, are also strong, and ritonavir, of course, are strong inhibitor of CYP3A4. And just to give you an example, this is the co-administration of PROD with the immunosuppressant ciclosporin, tacrolimus, and you can see that PROD will significantly increase the exposure of ciclosporin and tacrolimus. Interestingly, this study looked at what dosage adjustment we should do to overcome this interaction, and you can see that you would have to reduce ciclosporin to 1/5 of the dose in order to obtain ciclosporin trough level that are comparable to the level that you would observe without PROD. And in the case of tacrolimus, you would have to give 0.5 milligram once a week. So it is also important to mention that this dosage adjustment were validated in clinical studies. But you have to know that one of the issues with drug-drug interaction is that we don't always have clinical data on drug-drug interaction, and therefore drug-drug interaction are mostly predicted based on the knowledge of the disposition of individual drugs. Prediction can be sometimes difficult, as concentration of substrate or inhibitor inducer used in vitro study may not always reflect the in vivo concentration to which cytochrome are exposed, or the contribution of a given cytochrome may not always be scaled to its hepatic expression. And finally, as you know, some drugs are metabolized by several cytochromes which can be concurrently inhibited or induced. So one way to overcome this limitation is to use the physiologically based pharmacokinetic modeling. You heard about it a little bit before. This is a novel approach which allows to predict the pharmacokinetic in virtual patients simply by using in vitro drug data and implementing this data in a mathematical description of the processes that describe drug absorption, distribution, metabolism, and excretion, and also a description of a population physiology. And this will allow you to simulate the pharmacokinetic in virtual individuals. And this tool is of great interest for the prediction of drug-drug interaction. And here again, David Begg with Marco Siccardi had the great idea to use this novel tool to predict interaction between antidepressant drugs and antiretroviral drugs. And actually they used this tool first to assess what is the contribution of individual cytochrome to their overall hepatic clearance. So you see here venlafaxine, sertraline, mirtazapine, and citalopram, and also use this tool to assess what would be the impact of co-administration of a ritonavir boosted regimen on the antidepressant exposure. Here in brown, or a nefavirenz-based regimen on the exposure of the antidepressant. The number represents the ratio of the AUC of the antidepressant with the antiretroviral drugs versus the AUC of the antidepressant alone. And you can see that overall, this simulation predicts that the magnitude of this interaction with antidepressant are moderate to weak, which could be explained by the fact that these antidepressants are metabolized by several cytochromes, and therefore metabolism can still occur by cytochromes that are weakly or not impacted by the antiretroviral drug. So I think PBPK modeling is a useful tool to quantify the magnitude of drug-drug interaction, especially with antiretroviral drugs, which are characterized by complex metabolism, as they can concurrently inhibit or induce cytochrome. So we have seen that drug-drug interaction can occur at the level of absorption, metabolism via inhibition of cytochrome, or transport at the renal level via inhibition of transporters. But they can also occur at the level of absorption due to changes in gastric pH or complexation with mineral. You can see here, for instance, that Raltegravir absorption is significantly increased when it's administered 2 hours after omeprazole, which suggests a pH effect. Here again, David Begg and his team have looked at the impact of pH on Raltegravir solubility. And they have shown that Raltegravir absorption, they have looked at a Raltegravir absorption in different segments of the gastrointestinal tract at low, medium, and high pH. And you can see that Raltegravir solubility absorption is increased at higher pH, which can be explained by dissolution of Raltegravir pill, which is increased at higher pH. But they also nicely demonstrated that Raltegravir absorption can be impaired by the presence of divalent cations, and not only for Raltegravir, but all integrase inhibitors. And this occurs as if you look at the mode of action of these integrase inhibitors, they will go to the active site of the integrase, where they will bind to magnesium, so to any kind of divalent cation. So they assessed the impact of divalent cations on Raltegravir cell permeability using CACO2 monolayers. They applied magnesium at the apical side of these monolayers and evaluated the efflux ratio. And you can see that Raltegravir transfer from the apical side to the basolateral side is impaired in presence of magnesium, as it will form a complex, and Raltegravir won't be able to diffuse as well. Below you can see the clinical studies that were done for the combination of various integrase inhibitors with antacid containing divalent cation, and you can see that if you take these integrase inhibitors together with the antacid, there is a decrease in their absorption. But there is a way to overcome this type of interaction. You just need to separate the intake of this drug. So if we have seen that for integrase inhibitors, you can anticipate the interaction because the mechanism is well known. You have to know that in HIV therapy, it is not always the case. There are some interactions that are sometimes unpredictable. You probably all remember the interaction with boceprevir, tacrolimus together with boosted protease inhibitors. Although all these drugs are inhibitor of cytochrome, and you would expect that when you combine these drugs, they increase their exposure, you observe the other way around. There is a decrease in the exposure of boceprevir, tacrolimus in presence of boosted protease inhibitors, and the boosted protease inhibitors and for all drugs are decreased. So one potential explanation for this reduction in total drug concentration could be protein binding displacement. And more recently, there has been another intriguing interaction. This is the combination of sofosbuvir-based treatment and amiodarone, which led to serious slowing of the heart rate. And David Beck and David Berger discussed a potential mechanism to explain this interaction. Could be interaction at the level of intestinal transporters, or here again, potentially a displacement in the protein binding. So I think it is important, this example highlighted it is important to understand the mechanism of drug-drug interaction in order to be able to safely co-administer these drugs, and maybe for drugs that have more complex metabolic profile or transport profile, it could be worth to measure the unbound concentration. So I agree with you, it's a lot of information about drug-drug interaction, and how can we find easily information about drug-drug interaction. So here again, David Beck has been instrumental in providing information about drug-drug interaction. And it started back in '98, simple paper chart that summarized interaction for antiretroviral drugs and some given co-medication. And this paper chart have evolved rapidly into a website that you know was started in '99. Later on, a second website on hepatitis C drug-drug interaction was launched, and you probably noticed that this website has been redeveloped recently. And in terms of numbers, to give you an idea of what it is, what it represents, it is each website has about 600 co-medication, which means information on 15,000 drug-drug interaction pair. These websites are really a leading resource in terms of drug-drug interaction. They are used in treatment guidelines in many countries. Represent almost 1,000 unique visitors per weekday for each of these websites. So it's an amazing contribution in the field of drug-drug interaction. So looking back at drug-drug interaction, we can say that David Beck has somehow acted as a drug-drug interaction perpetrator with the concept of ritonavir boosting. But David Beck has contributed in the field in an amazing way in every level. First, by contributing to the clinical evaluation of drug-drug interaction by participating to drug-drug interaction studies with his team and collaborators, by evaluating the prevalence of drug-drug interaction, by contributing to mechanistic studies that helps us to understand the mechanism of this drug-drug interaction, by predicting this drug-drug interaction using PBPK modeling, and finally by providing information on drug-drug interaction with the website. So those are really a fantastic and amazing contribution. And I'd like to finish by looking back at drug-drug interaction numbers. So if you do a PubMed, you will find that David Beck has co-authored 167 papers just on the topic of drug-drug interaction. And as you know, he's a great lecturer. He's giving lecture all over the world. And this map shows you just for last year, he did only 50 talks all over the world, so I put his face in all the countries that he gave a talk last year. So I just would like to say thank you, David, for this amazing contribution, and thank you for your attention.